Well, welcome everyone to Strengthening Immunization in Alberta through equity-focused community engagement. We have a packed agenda today, so let's get started. My name is Mandy Roberts, and I'm the Policy Planning and Intergovernmental Affairs Manager for Western Region of the Public Health Agency of Canada. I join you today from Edmonton on Treaty 6 territory and Districts 9 and 10 of the Métis Nation of Alberta, the traditional home and gathering place for many Indigenous peoples, including the Neheyo, Dene-Sulena, Siksike, Sitapi, Nakota Sioux, Anishinaabe, and Métis Otipemisiwak. The incredible team that has made this webinar possible are from the University of Calgary, located on the traditional territories of the peoples of Treaty 7, including Blackfoot Confederacy, comprised of the Siksika and Piikani and Kainai First Nations, the Tsuut'ina First Nation, the Stoney Nakoda, including the Chiniki, Bears Paw, and Goodstoney First Nations. Calgary is also home to Métis Nation of Alberta Districts 5 and 6. So please take a moment to acknowledge the land where you work and live. Okay, well, welcome everyone, and thank you for joining today's session. This is the second webinar in Immunization in Alberta, a four-part series presented by the Public Health Agency of Canada, the O'Brien Institute for Public Health, and the Alberta Public Health Association. This series was developed in response to declining immunization rates, increasing misinformation, and an ongoing measles outbreak. The APHA membership identified immunization advocacy as a top priority, which is why this series brings together public health, academic, and community perspectives. Our first webinar in January focused on the future of vaccination for public health. Today's session focuses on equity-focused community engagement, how trust, access, culture, and relationships shape vaccine uptake. Our next session on February 23rd will focus specifically on vaccine hesitancy and misinformation in Alberta. We know that equity is central to strengthening immunization systems, and improving vaccine uptake in Alberta requires meaningful engagement with communities that experience persistently low coverage. Today, we will have a panel that will discuss clinical, community-based, and population health perspectives to share practical lessons, not just theory. We've intentionally ordered our panelists to build on one another, moving from outbreak response to trust and engagement to lived experience to Indigenous perspectives, and finally to a population-level equity lens. We plan to have about 30 minutes at the end of the discussion with the panelists, and they'll take about 4 minutes each to provide an overview of their work. So our first speaker is Laura Ma, Assistant Nurse Manager with Indigenous Services Canada's Communicable Disease Control Team in Alberta. Laura will ground us in the real-time realities of responding to the measles outbreak in Alberta last March, including what worked, what didn't, and why collaboration mattered. Building on that outbreak response, our next speaker is Dr. Annalee Coakley, co-director of the Migrant and Humanitarian Health Collective. Annalee will focus on trust, community engagement, and how structural barriers shape vaccine access and uptake for immigrant and refugee communities. Dr. Elena Castillo is a clinical professor in obstetrics and gynecology at the Cummings School of Medicine. Elena will share insights from her work supporting culturally diverse communities with vaccine decision-making during COVID, with a particular focus on vaccination and pregnancy and the critical role of trusted intermediaries. Our next speaker is Katie King, a registered nurse, health researcher, and PhD candidate at the University of Alberta. Katie's work focuses on vaccine confidence and cancer prevention in collaboration with the Métis Nation of Alberta and Métis settlements, and they will bring an Indigenous and community-based nursing perspective to the conversation. Our final speaker will be Dr. Turan Chowdhury, professor in the Family of Medicine and Community Health Sciences at the University of Calgary. turn will help us step back and reflect on immunization equity at the intersection of access, confidence, and power, tying together many of the themes we've heard today. So each panelist will provide a brief presentation and we'll introduce the next panelist. We'll invite the audience to enter any questions in the Q&A box at the bottom. And we'll hold about 30 minutes for a discussion period at the end. So I hope we can have a fruitful conversation. So with that, I'll turn it to our first panelist, Laura Ma.
Thanks, Mandy, and thank you for having me. As Mandy said, I'm Laura Ma, and I'm the Assistant Nurse Manager with the Communicable Disease and Immunization team with Indigenous Services Canada in Alberta. We call it ISC for short. So I'm speaking today from Treaty 7 on Tsuut'ina First Nation. So last year, March 2025, we were informed, or I'm going to share about the recent response to measles outbreak in a remote Northern Alberta First Nation. So March last year, we were informed on a Sunday night of a handful of confirmed measles cases in Little Red River Cree Nation. So this is a First Nation in Northern Alberta, close to Fort Vermilion. This was late diagnosis, so many were past their infectious period. However, most had been admitted to hospital while they were infectious. So this meant that there were multiple exposures in healthcare facilities, both on and off the nation. So this nation was one of a few spots across the province where measles was identified all around the same time. Thankfully, this outbreak closed in early May with minimal spread. There were, however, over 100 identified close contacts on reserve and additional close contacts off reserve, mainly from the acute care exposure. There were lots of lessons learned in this response. I've shared some on the slide here, but I'm going to focus on the immunization ones highlighted in blue. So just briefly, electronic medical records for immunizations was super helpful. This really helped to quickly identify if close contacts were susceptible or not susceptible, and they also helped focus immunization efforts. Another key lesson learned was the importance of a robust occupational health program for all healthcare workers. So of course, like your nurses and your nurse practitioners, but also your medical office assistants, your community health representatives, the security guards, housekeeping staff, all those considered healthcare workers or HCWs. Having systems in place to ensure healthcare workers have documented immunizations or proof of immunity is key. It's also essential to have this info before an outbreak occurs, particularly in a remote location. This ensures additional local resources aren't being used to quarantine healthcare workers, or you're not using resources to draw blood and send blood tests out to test immunity. And it also means that health facilities can work with their full complement of staff when they're needed most. There was a lot of success with immunization during the outbreak, though. Next slide, please. So this graph shows the impact of the coordinated response from the healthcare teams on the ground in Little Red River Cree Nation. There were 746 measles-containing vaccines locally administered between March 11th and March 26th. This is equal to 58% of all doses that were locally administered. That's measles-containing doses in all of 2025. So this was such a successful response at the time for a few reasons. Number one, we had the full support from First Nation leadership. So communication was happening daily between our ISC medical officers of health, or MOHs, and our First Nations leadership. Dr. Shireen, one of the MOHs from ISC, is going to speak more to this communication and advocacy at the webinar on the 4th of March, so stay tuned for that. But out of this collaboration for the outbreak, the chief harnessed social media to share information. So he was making daily Facebook posts or videos in both Woodland Cree and English. Some of these posts, when you look at them, they've been viewed 5,000 times. They've been shared 550 times. So really an effective way to get the message out about measles, what was happening, and where to get vaccinated. So the effort to vaccinate included all healthcare professionals on the ground in the nation, and additional nurses from the surge team, now called the INSAT team, were mobilized quickly. The local public health nurses handed over most of the contact tracing to the regional CDC team, and we completed that virtually. And that meant that they could fully focus on immunization. And then vaccine was offered at every opportunity. So your mass clinics at the school, temporary housing setups, there was mobile vans going out offering immunization, home visits. Sometimes these home visits were going to 10, 11, even midnight, just to try and reach people at the time that worked best for them. And then primary care was on board as well. So they had somebody show up at the nursing station worried about another health issue. They would also check their vaccine records and be offering at the time. So just really every opportunity that would present. So responding to outbreaks shows us what's possible under pressure, but sustaining immunization requires trust and engagement. So next, Annalee will speak to how these relationships are built over time. Thanks.
Thank you. So I'm Annalee Coakley. I've been involved in refugee health since 2009, and I became the medical director of the Calgary Refugee Health Program in 2012. And I left that role in 2024. My big learning from my career, like in terms of when I started out in refugee health, is that so much of optimizing somebody's health, I couldn't do it alone as a physician, and we couldn't do it alone as a clinic, and we needed to develop partnerships with community. So in refugee health, that mostly meant the immigrant serving agencies, different ethnocultural community associations, and the Alberta International Medical Graduates Association. And so our sort of my sort of lessons in my career were really fine-tuned during the pandemic. And so because my patients, many of them work at the meatpacking plants, and the meatpacking plants were some of the first large outbreaks of the COVID-19 pandemic in Alberta. My patients started to get sick first in Alberta. And I was asked if I could, and not just me, but the clinic team, if we could help mitigate the COVID outbreak at the meatpacking plants. And so, because I've never done anything alone, I do things in partnership. We invited all of our community partners from over the years to join us, both in, where the doctors and medical staff could address their health concerns, a lot of their social needs I couldn't address as a clinician. And so we would connect them to the appropriate social agency. When the vaccines first started to roll out, meatpacking plant workers were prioritized in the rollout, and we were asked to deliver the vaccine on site at the meatpacking plants in Calgary zone. And we just used our old playbook by inviting all of our community partners to design the vaccine clinic for the meatpacking plant workers, many of whom are newcomers and many of whom are refugees or temporary foreign workers. And so what we did is we did a lot of pre-work in terms of reaching out to different workers through either their community associations, their churches or mosques, through the union, or going out on site at Cargill and delivering first information around the vaccine in first language and delivered by international medical graduates who, in their own communities, they're just called doctors. They're not called IMGs. And so they're people of trust. They're trusted messengers. And so a lot of pre-work by those trusted members of the community was done so that when we eventually showed up at the meatpacking plant to deliver the vaccine, people were ready and willing to receive it. And so those vaccine clinics at the meatpacking plants were tremendously successful. And at the same time, northeast of Calgary had some of the lowest vaccine uptake rates and the highest COVID-19 prevalence. And so we wondered, could we take these lessons that we learned through the meatpacking plant and apply it to the community? And so what we did is we organized with our community partners, we organized a community-based, barrier-free vaccine clinic, and it was also very successful because of the community co-design, the community presence, people able to answer questions in first language. no appointments necessary, long clinic hours. They could come at 10 at night or they could come at 10 in the morning. They could bring the entire family. And so that was very successful. And ultimately, that started to be repeated on a smaller scale. And ultimately, in Northeast Calgary, they had the highest uptake of the first dose of the COVID-19 vaccine in all of North America. And so, again, it was a very successful model, and it was based in partnership. That's the reason why it was so successful. Thank you. And so, and part of that has to do with trust in the community partners and having a trusted messenger. And so trust is often built through people rather than systems. And Eliana's work highlights how trusted intermediaries shape vaccine decision making, especially in pregnancy. Eliana.
Thank you, Annalie. So I'm Eliana Castillo. I'm a clinician based in Calgary. By no means I'm an expert in newcomers or refugee health. I am sharing with you today the insights and learnings from a collaboration that was led by my esteemed colleague, Dr. Denise Campbell-Shetter, and Yvonne Yu, the director of the Multicultural Health Brokers Cooperative in Edmonton. During 6 months in 2021, the Delta wave, the Multicultural Health Brokers Cooperative in Edmonton, who speak, there is at least 60 languages, and they have been supporting newcomers in Edmonton for at least 30 years. Ask for academics based on the relationships they had before the pandemic to support them, answering the questions that communities had regarding all the vaccinations and the public health measures at that time. So we did a project in which we studied the decisional conflict around COVID-19 vaccinations in the communities using a pragmatic research method called sense-making. And just to reinforce what Annalie just said, the foundation is trust. So I have a bridge here, and the way I understood the incredible work that brokers or community intermediaries or community health workers or the different things that we have is that they bridge, link, mediate between groups of persons or different cultural backgrounds, and in this case, between the communities and the formal systems, for the purpose of reducing conflict and producing change. So we tried to understand how brokers do what they do. And the conclusion was that the foundation of this bridge was the trust. And the trust is, and how do you define trust? How do you build trust? How do you keep trust is beyond of what I can discuss today, and I certainly cannot begin to understand it properly. But there were, next slide, please. There were 5 insights from this work where we met once a week with the brokers, and they would bring the questions they had from their communities. We would try to answer them, and we would actually meet sometimes with the communities. So the messages could be coming from the trusted intermediary, just as Dr. Coakley said. So what we learned is that in moments of crisis, starting the communication early is crucial. We also learned that we need to constantly tend to the relationships between us, and I'm speaking us as those of us who are in the formal systems, and the community. And we cannot begin to create that relationship at a moment of crisis, because those relationships need to be tended to. They are like plants. We cannot make a plant at the whim. Plants need water and light, and we need to constantly ask what they need. And that's the relationship that we need to tend to with the intermediaries, who are that crucial bridge between our formal systems and the communities we need to serve. Build grassroots coalitions that can mobilize support. And again, the only way to mobilize support fast enough is that there is a connection and a mutual trust that is already established and is tended to. To recognize security, the time and the space needed for sense making. So it was amazing to see how adaptable the intermediaries became at supporting the communities via Zoom, having to learn and adapt to infection prevention and control. And very importantly, to foster sincere engagement with a non-judgmental stand. The way I look at this, fostering and maintaining and tending the relationships between us as formal systems, the intermediaries who are always there working without being seen, underfunded, is part of pandemic preparedness. Millions, if not billions of dollars goes to vaccines, to masks, to protocols. And if we look at actually the funding that organizations like the multicultural health brokers live with, it just doesn't compare. And yet, when we really need to reach the workers at the meat packing plant, as Annalie was talking about, or the Somali community in one of our cities, it's in those moments that we remember that the intermediaries exist and go to them. And I really, really hope that part of the learnings from our pandemic preparedness is that we need to tend to those relationships. And I didn't speak specifically about pregnancy, but there is only one message that I want to convey, and it is that it's not that necessarily that newcomers or pregnant individuals are more hesitant. I think is that it is normal that they have more questions. And I will leave it there. So KD is coming next. And the same dynamics of trust and lived experience that I have just spoken about are central in Indigenous communities, and KD will share how this play throughout through a nursing and Métis health lens. Thank you, KD.
KD, we can't hear you.
That would be helpful, wouldn't it, if I was off mute? Thank you so much, Eliana, Annalie, Laura, and Amanda. I want to talk today a little bit about immunization equity in the sense of the Métis community, as that's where I've done most of my research. And we can go to the next slide. So I want to talk a little bit. I was involved in the Métis Nation of Alberta's, Otipemisiwak Métis government here in Alberta's COVID clinic response. And I can't help but echo so many of the sentiments that have been shared by my colleagues today in terms of, grassroots mobilization, having those trusted advisors in their communities, and how important it is that cultural factors are included in the work that we do around immunization. both in the COVID clinics and in my own research around HPV prevention and HPV vaccination. What I've heard from community members over and over again is how valuable it is to have a Métis specific response. And, you know, in the broader First Nations, Métis and Inuit conversation that we have here in Canada, we often are talking about distinctions-based approaches. You know, what's unique and wonderful about one community will be quite different from what's unique and wonderful about different communities. And so making sure that our responses, when we think about equity, are really thinking about those unique needs of communities. Some of the things when I met with parents and talked to them about HPV vaccine, for example, you know, there was stark differences between the experiences of Métis parents making decisions around HPV vaccination in rural and remote and settlement communities than our Métis parents in urban centers, where school-based programs are very electronic-based, consent is sent electronically, and parents might have opportunities to or have higher levels of health literacy, better able to understand some of the information that's sent home, and then also just better access to public health expertise in their communities. You know, often in the North, there might be one public health nurse for a large geographic area. And so even access to talk to a live person about vaccination decision-making can be a challenge in those communities where there's not a local person that can be, that's necessarily a trusted advisor. One of the other things that I think often comes to mind in my work is also thinking outside of like ethnicity and those sort of community identities for like Two-Spirit, LGBTQIA plus communities. You know, there's unique barriers that different communities face. And so what my research and my experience as a public health nurse is sort of really showing me is that we need to sort of customize some of our messaging around vaccination in order to make it more equitable. We have sort of a broad message that we send to parents. And Eliana, I, as you were talking, I was thinking about the new parents in my family, in my kinship circles, and how the messaging that I got during my research as well from parents saying, you know, I want to do what's best for my child. It's just not always that clear, especially in the context of, you know, misinformation and disinformation that's often available through social media and things like that. And so how do we leverage those community members who have influence and knowledge to make sure that the right information is getting to our communities so that they can make those informed decisions and do what's best for their family and children. Some of the other things that came out of my research really go back to this idea of like community-specific interventions. Thinking exactly about rural and remote communities, what can we do to bolster confidence in those areas, what we can do to bolster access and acceptability. Métis youth told me that you know, incentives would be useful for them when getting their like adolescent vaccines. So sort of thinking outside the box in terms of getting those needles into people's arms. The other thing that came up in my research was improving access to school-based programs. So how do we get those school-based vaccines to be available if children miss school? How do we like make in small classrooms, maybe in split grades, how do we increase our flexibility in terms of delivery for some of those groups? And then of course, making sure that the information that we do send home to parents is really accessible in terms of both literacy and sort of cultural sensitivity. A strong message that I've often heard, particularly around HPV, is around the messaging about it being a sexually transmitted infection and sort of a de-emphasizing of the prevention of cancer in some of the messaging, and how that can be that might be a useful way of reframing some of our messaging to make it more accessible to different communities. Lastly, I think we need more research and more focused input on distinctions-based approaches. Different First Nations, different Métis communities, and our Inuit relatives as well. So making sure that our approaches are tailored to those communities uniquely. And actually, you can probably skip the next 2 slides because I think I'm running out of time. But I do want to say thank you to you all. And, I've given a few specific examples around HPV and COVID, but I'm going to pass it over to Turin here, who is going to talk to us a little bit about deeper conversations about equity, power, and access when we're thinking about immunization at the population and systems level. Thanks so much.
Thanks, Katie. Thanks, the team. I think you guys have shared a huge body of knowledge, experience that we have done to overcome the immunization inequity and equity-focused community engagement during the last 1 decade or previously as well. So the next slide, I just wanted to show you one thing. Like, this is the way we started thinking when we started thinking, okay, so how to approach this? As Eliana mentioned, that this is a long game. This is not a short game. Unfortunately, it happens to be a short game. We get a knee-jerk reaction of something happening, like COVID, or even if it was is a reaction to COVID. If it come and the situation, but we look at, if there is a future Dovid, we probably a Lovid or Movid, whatever we call it, it looks like we will be in the same place of doing a knee-jerk reaction. So if I'm looking at the community, now I see different group of people in the community, and we see different group of people. The first group of people who don't know. The second group of people, we see that people who knows, but they don't care. The third group of people who we look at is like more of a people who know, who care, but don't understand, get the grasp of how to overcome those. The fourth group of people, we see that, people who knows, who cares, who understand, but doesn't have access to, overcome the challenges, overcome the issues, overcome the vaccines, overcome the immunization so that they can overcome the problem. And the last group of people is like, who knows, care, understand, with support, once in a while can access, but cannot apply a sustained way in their life. And if you look at the right side, the issue of not knowing is a sort of an awareness thing. The not caring is the motivation thing, and not understanding is the learning component. And then the access component is there because just learning is not enough. We need to support them for access. And then the social determinants that we have been talking about, I think everybody alluded to, is the component that we need to capture and come up with how to handle those things. So the next slide, please. So this, if you think about the trust and access related components, so both need to be in place. So this awareness, motivation, and learning, these are the components where we get people's acceptance when we work on this one. With acceptance, with long game, builds the trust. And then to maintain the trust as well as continuing working with those components, the access and the social determinants need to be pulled in, and our programs, our way of doing things need to be an infinite game, which is working on access and trust. And the one more big fueling in the next slide, we have shown that this power component comes into this because there are power pushing, power pulling as well. This whole scenario of this one. So I may use an example to talk about the power. For example, we have been talking about social media, like misinformation and disinformation. We know the current social media controllers or the power holders, they are day by day reducing the flow of real information or conventional news outlet-based information, and they are reducing those materials to be flowing through social media rather than they are letting people created contents, hoax, flukes, and they know the catchy, fancy information because there is this power of money, power of getting entertainment, and power of trying to mislead people. All are mixed up down there. So this is proper news or proper information is difficult. Apart from the examples we saw that example we saw one of our speakers who told like their team used the social media for their sort of a positive impact on the vaccination about the measles. So these components, if we cannot think about, if we cannot visualize, we will not be able to play the long game that, probably came up from all the speakers' statement, and Aliana mentioned it specifically. So the power shapes both trust and access. And because power is the component where we understand who controls the resources, who make the decisions about all these components to be in place that we are seeing in the screen, and whose knowledges and voices are prioritized, and what narratives dominates. Because because it goes both ways. If we put all the access system in place, if we cannot convince people to be feeling like I am a candidate of this service, they will not avail this service. Or if I'm ready to get services, but if the access are defined by, being in urban area, being in very easy area for the health system, that power, then they will not be able to access. So I think for the long game, the power informed way of approaching this and coming up with plans will be so important. And that's all for me. Thank you.
Everyone, thanks so much for your insightful presentations. I'll ask the panelists to put their cameras back on so we can get ready to answer some questions from the audience. Maybe to get the conversation started, I'll ask the panelists, based on what you've shared today, what is one misconception about vaccine hesitancy or low uptake that you think needs to be most reframed? I'll open the floor.
So I was the last time, so I will go first. Anyway, so I think to me, the biggest myth is the vaccine hesitancy or low uptake is just a matter of willingness. So that's the biggest myth to me. Because, in reality, decisions are shaped by, structural factors, inequities, and misinformation, all influence whether people can feel the confidence, the acceptance to get vaccinated or not, feeling them as a candidate for vaccine or not. So that's the biggest misconception in my head. I mean, in my realization, like low uptake, hesitancy is not just a matter of willingness.
Thanks. Anyone else?
I will build on that. So yes, I would completely agree with what Turin said. My experience during the pandemic is there was a lot of victim blaming. So in Northeast Calgary, where they had very high rates of COVID, our political leadership was saying it's those people, it's the way they live their lives, and they don't want the vaccine. Where I have always found that my refugee patients really appreciate vaccine because they know the alternative. And so what my take home is that, really vaccination systems are designed around certain assumptions. So assumptions about, reliable, transportation, stable work hours, digital proficiency and literacy, et cetera. So once you are able to design something in partnership with the communities that you're serving, then the barriers start to be identified and stripped away, and then people show up for the vaccine.
Beautiful. Didn't catch the order. I'll go to Katie.
Yeah, I also just building on that, I would say the biggest thing is that vaccine hesitant folks are really all opposed to vaccines broadly. Often, I think there's a very small group of people that are actually vehemently opposed to vaccination. There's a very large group of people who are unvaccinated or partially vaccinated or undervaccinated who just really need more information that's delivered in a way that they can understand and by people that they trust. And so for me, I think the biggest myth is that there's more people that are vaccine hesitant or vaccine opposed than there actually are. I think it's really about the communication that we do and how we reach those populations in a meaningful way, as Annalee and Tanver or Turin both have said.
If that's okay, I will go next.
Oh, please. Yeah.
So thank you. And so again, to reiterate on what my co-panelists have said, in the same way that as I shared that I think it is normal to have questions in pregnancy. It is normal to, as a newcomer, to try to make sense of everything that is coming at you. And I always go back to try to review what this decision of decisional conflict is, and it's the uncertainty experience about what to do when choices involve risk, potential loss, or challenges to personal values. It's normal that people have questions. It is normal, and again, this is speaking for pregnancy, even and in our research, even people who is vaccine acceptant prior to pregnancy, they have questions about what it would mean to vaccinate during pregnancy. And when I think about our newcomer populations, the question or the situation is not that different, especially when the access remains such an issue and continues to get worse, unfortunately, in some aspects in our province.
Said Laura.
Yeah, just building on what my co-presenters are saying, I find that there's very few people that are absolutely hesitant or don't want vaccine. It's often have some questions. They've maybe read something on social media or wondering about it, and then maybe they don't have transport. Maybe they need to spend their resources to go get fresh water to be able to drink, and so getting vaccinated kind of goes down the priority list. So I think trying to approach it with, when you have an opportunity to vaccinate them, let's look at everything and be a bit more holistic and answer the questions and reduce the barriers and try and do what you can when you're seeing people, as opposed to limiting it to one vaccine.
Something I was also just thinking of, sorry to just jump in, Amanda, but I was thinking about access points too. If vaccines were available at more access points, like I think about in my own work around HPV, I think about like dental assessments. People do head and neck assessments, and it's a good time to ask, hey, have you been vaccinated against HPV? It prevents head and neck cancers. Or, there's just more frequent contact with health providers who could prompt about vaccination, I think would make a big difference as well, because it's often those trusted providers that they're seeing, their pharmacist, their, the person that they see more regularly, that could provide that trusted recommendation that puts someone back into the zone of getting it done.
Great, thank you so much. So we have a question from the audience. It might be directed towards you, Katie and Laura. How can healthcare providers providers better integrate cultural safety practices into routine immunization encounters?
Yeah, I'm happy to jump in on that one. One of the things that I do is, like, in my clinic, we all have we all wear lanyards, but we also have like a pride flag outside of every clinic room. So that tells our 2S LGBTQIA plus relatives that this is a safe space for them and that we are open to using your pronouns, using your correct gender markers, preferred names, etc. We ask about those things in our intake forms. We make a concerted effort to increase cultural safety. I know this is like something that sounds silly, but we have like land acknowledgements framed in each clinic room. We try to do additional training with staff around First Nations, Métis, and Inuit specific cultural stuff. So everyone has at least a bit of knowledge. So if a client comes in who has an identity that is First Nations, Métis, or Inuit, and there's something relevant that comes into the conversation, at least staff are aware. Personally, as a Métis person, I usually am wearing something that indicates to other Indigenous people that I'm Indigenous. And so that often is an icebreaker. But yeah, I think having just a baseline knowledge of different people's potential experiences, whether that's newcomers, First Nations, Métis, or Inuit people, is a useful thing to have in your tool belt. So that if those things come up, you can talk about them.
I'll just add on a couple other things we find. The feedback I've had is that, if you have nurses that have seen a family for maybe prenatal care and been involved with a family, then you're going to have a lot more success with offering childhood vaccines and through the age groups there. So just that building relationships and also using the community health representatives, that seems to really be helpful as well.
Super.
And also to add to what Katie was saying before about taking, meeting people where they're at, meeting people where they feel safest, where they're surrounded by people that they're comfortable with. I think that also goes a long way to improve cultural safety or just, safety in general.
Oh yeah, absolutely, Annalee. Something popped into my mind. I do a lot of work with Dr. Shannon McDonald, who I think is presenting next week as well. And we did some work out at Masquachis. They did a big health fair. And one of the resounding messages from the community was like, oh, we should do more of these. Like, why don't we have a health fair at the powwow? Where people, we're already gathering as a community. So, maybe we should have a few vaccinators and sexual health workers and other, people available if people want access. So really, bringing it where people are.
Yeah, because it's often
in the epidemiological triangle.
Yeah.
Yeah.
Yeah, it's our institutions that feel very uncomfortable for people, right? Like they're overly bureaucratic. It has just a completely different vibe if you're actually in their home, in a place where they feel most comfortable. And I know that that's usually what I sort of employ with the refugee communities that I serve. And I feel like there's much greater uptake when you go to people rather than make them come to your, my sterile clinic, etc.
Great. Okay, we have another question. How are you addressing vaccine hesitancy and access now with massive barriers implemented by the province? For example, COVID fees for the COVID vaccine rather. Enrollment for flus and COVID vaccine.
That's a very good question, and one that makes me wild. So I can't do very much about the fees, but what we have employed is vaccine navigators. And so the Alberta International Medical Graduates Association, they have trained navigators and they're also trained in interpretation. And so we have them help us get connect the patient to the vaccine. And so they've been invaluable for us.
Sure.
Well, we actually on First Nations didn't charge for COVID vaccine this season, unlike the rest of the province. This is directions from our medical officer of health. And we actually saw an increase in uptake in seasonal immunization, so over 20% compared to last year. So whether that's because it was, they've been in the media about this cost and now people, were more interested in it because it seemed more difficult to get, but it definitely, we did see a difference there for sure.
We have another question building on that. What extra resources are needed and how should they be deployed for maximum effect? I'm wondering, how are navigators funded? Where are the places that could have the most impact?
I think this is a big gap in our system because health navigators are not funded. Eliana also talked about the multicultural brokers, who are like a type of navigator. And they are operating on a shoestring. The Alberta International Medical Graduates Association, they have funding for the program, but they are unpaid. It's unpaid work. And really the exchange is the internationally trained physician is exposed to the Canadian system and learns, and we provide a bit of feedback and et cetera. So they get that in exchange, but it's unpaid work, which doesn't sit comfortably with me. And so, yeah, all of the studies have shown that it's cost effective to have patient navigators, and I would really love to see it universally accessible for our patients, and not just for refugees. I have plenty of English speaking patients who really need like an extra hand being connected to healthcare resources.
Are there any other resources that are needed to support?
I mean, I would say for urban Indigenous people, we've seen, the community support workers, the community resource workers, a decline in the number of them that are high or are available. So I think, some sort of program that would support more Indigenous people to be working as trusted providers in their communities. Again, it's a funding, I think, issue. But certainly in my work, especially doing outreach, we know that our community support workers have a big impact. They make a big difference in terms of connecting, especially with urban Indigenous communities.
And we wouldn't need so many navigators if the system worked for everyone. If I had access to the vaccine at my clinic, if I had vaccine, that would automatically reduce a bunch of barriers. But instead, we're not even, the province holds the vaccine. So if I wanted flu vaccine, I can't just order it myself. That's dictated to me by the province. COVID vaccine, routine vaccines. I can't purchase them on my own. I can't access the vaccines to be able to overcome some of those barriers that my patients face. And so I'm dependent on patient navigators who they work very well, but it's just all these extra steps. And there's always a chance patients will fall through the cracks every time you insert another step in the process.
On that note, we did a study just on access, specifically a few years ago, and on access, like point of care access to immunizations. This is before COVID, right? This was just influenza, not a sexy vaccine then. And we looked at 3 influenza seasons where we did not have the flu shot at point of care in the clinic, in the pregnancy clinic. And then we went through 2 years of conversations with public health and et cetera, and we brought the vaccine. The influenza uptake, again, during pregnancy, went up by 36%, and it was sustained just by having the vaccine on site. So for 30 years now, we've been talking about patient-centered care. We continue to provide provider and health system-centered care. There is no question that it's easier to track vaccine uptake if the vaccines are given, at the public health office, right? There is no question that it's easier to track if they're given in pharmacies, right? So in order to make sure that we have good numbers, then we limit access. And yet, we have amazing technology, like, barcodes and cell phones are everywhere that could overcome those issues. So anyway, it's a philosophical question.
So we have one last question, and I think it's a great place to end, and that is, how do we measure success in equity-focused immunization work beyond just coverage rates? Quick 2-minute answer here. Does anyone have ideas?
I would say relationships. I think, the more relationships that public health workers, communities, institutions have with equity deserving groups, you know, and I mean real relationships. I'm talking about knowing the people by their name, maybe how many children they have. All my work is grounded in community-based research methodologies, and I keep in touch with everybody year round. Christmas cards, you know, it's an ongoing commitment to being a good relation, and I think that's an important piece.
And maybe we could ask the patients, clients, people, like ask the community, is it working for them?
Wonderful. Well, thank you so much for your wisdom and lived experience today, and just a really great conversation. So I want to ask the attendees to please complete the post-event survey. Thank you for your engagement and for your great questions. And I just want to say to this whole community, thank you for all you do to promote immunization in your work. It's just so touching to hear what you do. Yeah, so please join us for our next webinar. It's February 23rd about understanding vaccine hesitancy and misinformation in Alberta. Katie said that Shannon McDonald will be there, so she will indeed. Registration will be available soon. So thanks for being here today.
Thank you.
Thank you.
Thank you, guys.
Thank you so much, Amanda. Thank you, everyone.
Take care.